This video is about a very unusual situation where, due to scleral necrosis, and this was due to a explant which was placed on the skull surface for management of retinal detachment, and this dig into the sclera, and with time there was a scleral necrosis and leakage of aqueous. So this is the patient who had some kind of blunt trauma, and we can see the evidence in form of a torn sphincter and a traumatic mydriasis. And this patient was operated for his retinal detachment, and the scleral buccal placement and an insert large element was placed. And with passage of time, this patient developed extrusion of the implant, and this was, as it is seen here, on a slit lamp examination, we can see a portion of the silicone solid rubber explant which is protruding through the conjunctival gap, and there are sutures also. And this patient had presented with this extrusion and it was planned for removal, but patients deliberately delayed this advice, and later on the patient presented with a situation where we can appreciate some corneal folds because of extreme hypotony, and we can also appreciate the presence of choroidal detachment and collapse of the posterior part of the globe, showing choroidal folds, and the retina was settled in this case after the buccal surgery. So this is a complication because of a retained scleral explant which was placed for management of retinal detachment. So once suspecting that probably there is scleral necrosis in this area, which is causing a continuous leak of fluid from inside the eye, a surgery was planned to remove this explant from its position and explore the underlying sclera. So removing an explant is a straightforward process, and I always wondered that although placing an explant needs something like an hour of surgery, however removal is so straightforward and quick. Here we can see the encircling element junction has been identified. A portion of that is cut off and the encircling element simply slides out by pulling it out. The sutures which are there can be simply excised and pulled out. Only one end of the suture should be cut off so that the remaining loop is pulled out, and if you cut both the loops, invariably the central part of the loop will be left behind. So it's very important to remove sutures, and then when you're removing, you simply cut off only the one end. This is the skull buccal explant. Seems like a 7 mm explant which has been trimmed to 5 mm as per the requirement, and removing the other suture which is visible to us. Now once these sutures were removed, the surface was exposed and a Seedless test was done to ascertain whether there was a leak. So we didn't expect a leak as seen on a Seedless test when it is done on anterior chamber, because there is a liquid aqueous, and here we have just a wisp of some vitreous. The vitreous wick which is extruding out from this portion is getting stained and diluting the fluorescein dye which has been applied there, confirming that this is the point of leakage. Other sites were checked, and however there was only one point which was leaking. So it was decided to seal this using cyanoacrylate glue, and cyanoacrylate glue is a agent which gets polymerized on contact with humidity and water. So the surface has to be thoroughly dried, and this was loaded onto a syringe where a drop has been placed, and it simply percolates into that space and gets polymerized immediately. The extra dye which had polymerized outside the lesion was simply removed just by pulling it away, because that portion which is already wet, the dye doesn't stick to those surfaces. So here we see a portion of the polymerized cyanoacrylate which is seen attached at the caruncle at the medial canthus, and this can be simply pulled away and gets peeled out easily. Whole of this procedure was done under local anesthesia by giving a retrobulbar injection of lignocaine 2%. Looking at that as an exact size, we could appreciate that this is going to irritate the patient. So we decided to trim this portion of the dye which has polymerized in form of a rough surface. So we simply used a scissor to trim this in a manner so that extra portion which is protruding out is trimmed away. So using a 1/2 scissor, this extra protruding portion was simply trimmed off, taking care not to dislodge it from the surface where it is sticking. This completes the procedure, and then we had to wait for a while. So this is the picture at about 15 days after this procedure, and we can appreciate that that portion is properly healed, and on examination we can also appreciate presence of an intact epithelial membrane and some amount of vascularization. Siedel's test, although it is not recorded in the video, but it was negative this time, and this patient was treated of the condition. Thank you.